Now, I have reached to the one of the very important part of this lecture again, and that is investigation. Now, how do we confirm the diagnosis of a meningitis? Now, let me give you some guidelines first, and then I'll move on to the proper discussion. There are two investigations which are most important for the confirmation of meningitis. Can you guess which are those two investigations? Yes, there are so many we can do, but these two are the most important one. Which are those?
CSF check, we check for bacteremia, and also most common physical signs.
Sir, there will be a low sugar level as well in CSF. Low sugar level, sir.
Okay. Now this is a bit of a vague question for you at this juncture, but there are different types of examiner. Okay. Now let me share my perspective. My professor, when I studied my MD, always asks question like this. Always. He never asks question, can you tell me the clinical features of meningitis? No, nothing like that. He always asks, can you tell me two most important investigation in bacterial meningitis? Now, which are those two? I need to think for a while, isn't it? So some examiners are a bit of difficult type. Okay, they want you to know your content in so much better way that they modify the questions and then ask like that. Now see there. Let's list the investigation first. Okay, one is CBC. CBC. We always do that because this is a bacterial infection. Any type of infection, CBC is done. Another is blood culture. Blood culture. Remember the pathogenesis of bacterial meningitis. Hematogenous route is the most important one. So same organism may still be present in the blood. So blood culture may pick it up. Okay. Third thing is CSF analysis. CSF analysis by lumbar puncture. Because this is meningitis, so it is the important one. And fourth one is a CT scan. Now, so many times, okay, we don't want to go for lumbar puncture or CSF analysis before going for CT scan. CT scan will give us whether it is or tell us whether it is a case of raised ICP, whether there are some complications already present or not. For example, brain abscess, subdural effusion, okay, or something like that, even hydrocephalus. So CT scan. Now, out of these four, if I want to choose two, I will go for CSF analysis and CT scan, okay, as the most important one among others. But others are also important. Okay, I'm just choosing which are more important because CSF analysis will give me the confirmatory diagnosis, and CT scan will tell me if CSF analysis is not possible sometimes in a very sick child. If there are some contraindication for lumbar puncture, then CT scan will give me the diagnosis. CBC may be high in so many other bacterial infection. So this is a bit of non-specific, and blood culture also may be positive in other situation also. Okay, but along with clinical feature like history taking and physical examination, if CBC is high and blood culture is positive, it really gives us a lot of important points. Now, let's focus on the lumbar puncture. Now, first of all, the examiner will ask you, what is lumbar puncture? Okay, so what is this? What do you mean by lumbar puncture? Yeah.
Yes. So we insert the needle in the subarachnoid space in the spinal cord, below the spinal cord where it ends, and below at mostly at the anterior vertebra. And we collect the CSF for the checking of the bacteremia and the septicemia.
Okay. Now, yeah, you can. Now you tell me. Yes.
Sir, basically, sir, sir, we do lumbar puncture, sir, using that needle, sir, at sir, I said the posterior iliac crest, sir, at the level of the L3 and L4 vertebra, and sir, we take the CSF fluid and sir, then we examine it. So this is the main lumbar puncture.
Okay, you're absolutely right, both of you. You already have got the concept. Lumbar means this level of lumbar vertebra. Lumbar, okay. Puncture means there is a specific needle, special needle, which is available in the hospital, in the ward. You just order that, the sister will bring that whole set for you. It's a special type of spinal needle, which is put inside from that specific area, and the tip of the needle will reach subarachnoid space, and the shear shape which is there would come out from the needle, and we collect that specimen. This is known as lumbar puncture. Now, one other question is, what is the level of the lumbar puncture? One, you already told me, it is between L3 and L4, okay, vertebra. This is the most commonly used. Very rarely, or sometimes even L4 and L5 vertebra is also chosen, but preferably it is L3 and L4. That's the first thing. Second, which are the layers, okay, which are pierced by lumbar puncture needle? What are the layers which are pierced by lumbar puncture needle? Now, let me write it here. This type of questions also can be asked to the students sometimes, just to check their anatomical knowledge. These are layers crossed by the needle during lumbar puncture. Okay, the first one is the skin, then subcutaneous tissue, okay, you can write one or two or one. Now number 3 is supraspinous ligament, okay, spinous ligament. This is number 3. Let's write number 2 here, okay, because skin and subcutaneous tissue are written as first. Then interspinous ligament, then okay, then we move on to the ligamentum flavum. Wait for a moment. Okay, number 4 is ligamentum flavum. Then another one, okay, number 5, after ligamentum flavum we reach the dura mater, and then arachnoid mater, okay, and then you enter into the subarachnoid space. Means subarachnoid means you have to pierce the arachnoid mater as well. These are the layers which are crossed by the needle. Okay, so let me correct the spelling of the needle here. Okay, sorry, there's a problem. Okay, you can correct it on your own. Okay, so these are the different type of layers. Some of the teachers may ask you a question like this also. Now let's come to the point. During the lumbar puncture, the shear shift pressure should be noted. If pressure is very high, okay, then we suspect there is too much raise in intracranial pressure, which is seen in bacterial meningitis. If the pressure is not that high, then we may think about viral meningitis, or even the normal shear shift picture. So shear shift pressure is the first thing. When ICP is elevated, LP should not be done. Why is that? Anybody? Why raise in ICP? If the severe rise in ICP, LP should not be done. What's the reason?
Sir, it's indicate the sign of bacterial meningitis. Because in bacterial meningitis, it's increase in pressure.
Okay. Any other students? My question is, if shear shift, the intracranial pressure or ICP is very high, okay, LP should not be done at this time. What is the reason?
Sir, there is a high chance of herniation in the brainstem.
Okay, good. Yes.
It may be there a chance of compression of brainstem.
Yes. Now.
So you already have hypertension.
Yes. Now Now, let me explain this point again. You're absolutely right now. Now, remember, in case of adult and in case of kids who already cross 18 months of age or older children, let's talk like this. Okay, there is a high chance of herniation of the brain if ICP is raised. Okay, substantially raised, because when you do lumbar puncture, remember there is sudden release of the pressure which is collected there. That sudden release of the pressure, okay, will lead to a pushing down of the brain, and that can result in cerebral herniation. That cerebral herniation can kill the patient sometimes. There are different types of herniation you have already studied, okay, in basic science. These are transtentorial herniation, okay, and then tonsillar herniation, then herniation occur at the level of falx cerebri, isn't it? So all those different types, but the most important one here is transtentorial herniation and tonsillar herniation, which can kill the patient. Because of this important reason, CT scan of the brain is done in the suspected cases, and if CT tells us yes, it is safe to go for lumbar puncture, then we'll go for it. Okay, this is the take-home messages from today's class. Yes, in pediatric age group, it is relatively safe, especially in small baby, because they have got still, separated suture which are not fused. They still have open anterior fontanelle, so there is no chance of herniation of the brain because pressure is dissipated out from the skull. But after the fusion of those things, after the closure of fontanelle, in adult and bigger children, there is always a risk. So why to take that chance? I can diagnose meningitis even without going for lumbar puncture because of some other thing. And at last, if I cannot diagnose, I can start antibiotic just under the suspicion. That point is always there. Okay, so don't take any chance if you are in doubt. Color of the CSF should be noted when you take it out. Very important one. Normally, the color is like water. It doesn't have any color. If it is, having bacterial meningitis, then it is turbid, or it is frankly pus. So this is important point. In viral meningitis, it is still clear, okay, normal color. In tuberculous meningitis, it is again a bit turbid. So these are the different points there. Sometimes it is mixed with blood. Okay, it is mixed with blood. Now, what are the causes when CSF is mixed with blood? Anybody?
Trauma, malignancy.
Trauma, malignancy. Yes. Any other? One more. Subarachnoid hemorrhage, isn't it? Subarachnoid hemorrhage. So now, let me elaborate a little bit about this because this is an important part. The most common cause of blood present in the CSF is during your lumbar puncture itself, when you hit some of the blood vessel on the way. Okay, this is known as traumatic lumbar puncture. This is the most common cause. So if that happens, okay, then I will stop doing lumbar puncture for this moment, and probably I'll repeat it again after 24 hours. Okay, this is a very important one because otherwise the interpretation of CSF is difficult. There will be a lot of RBC present. Along with RBC, some WBC will also come in CSF. So analysis will be difficult. So it should be avoided as far as possible. And if very experienced doctors, they will not hit these blood vessels when they are doing lumbar puncture. Okay, they are quite experienced doing that. The second thing, in case of subarachnoid hemorrhage, because of any reason like rupture of the berry aneurysm, any trauma, okay, any bleeding disorders like that, the CSF is red throughout. It is red throughout. Okay. So these are some of the important points. Now, after you take CSF, what are you going to do? CSF is sent immediately for examination in the lab, including total leukocyte count, and differential count, protein, and sugar. These are the most important tests. So what is total WBC? What is the differential WBC? How much protein, how much sugar? And one CSF sample is sent for gram stain and culture and sensitivity as well. Okay, we should not forget that. Normally, CSF glucose is greater than 2/3 of the blood glucose. And in bacterial meningitis, CSF glucose becomes less than 2/3 of the blood glucose usually, because those bacteria, they consume the CSF glucose which is present there. Okay, so this is very, very important point. Now, I should order the random blood sugar also in my investigation. Then only I can calculate what is the 2/3 of the blood sugar. This is important point, and so many times we ignore this. I'll give you one small example here. For example, this patient is a diabetic patient, but this patient is a hypoglycemic patient already. And during that situation, okay, if we do not follow this 2/3 of the blood glucose rule, we cannot say whether this much sugar is already low according to the blood sugar or is it normal. That's why always follow this rule. You don't need to do anything, just order blood glucose and calculate what is 2/3 of the blood glucose. That's it. And compare that amount with the CSF glucose. If it is less, there is high chance of bacterial meningitis or tubercular meningitis. Protein is usually elevated. This is the rule of bacterial meningitis. And total count is usually high with neutrophilia. More than 80% of the cells are neutrophil in case of acute bacterial meningitis. So to summarize, WBC count is high, majority of them are neutrophil, protein is elevated, and sugar is low. This is bacterial meningitis. Now, I was talking about investigations in case of bacterial meningitis and specifically on CSF analysis or lumbar puncture. These are the CSF parameters in different forms of meningitis. It's absolutely important slide. So every student, okay, who are attending this class, please pay attention. As a doctor, you should be able to interpret the CSF finding. Okay, is it normal or abnormal? That is the first thing. Second, what type of meningitis is this? If you pay attention, you will clearly able to diagnose that. Now, first of all, we should know what is the normal values. Regarding the cells, okay, there are less than 5 cells in normal CSF, and all of them are mononuclear cell, that means lymphocyte. Okay, not even a single neutrophil should be present in the normal CSF. Not even one. Remember that. Okay, even one neutrophil present in the CSF, that signify there is infection. The amount of glucose which is present in CSF is 2/3 of the blood sugar. 2/3 of the blood sugar. Okay, so the range is given here, that is 50 to 70%, but the average is 2/3. 2/3 means 66%. It is easier for us to remember like that. That means first I need to order what is blood sugar level. I need to calculate what is 66% of that blood sugar level. And if CSF sugar is less than that, then only it is decreased glucose in the CSF. Okay. Normal protein is 15 to 45 milligram per deciliter, and normal pressure, which is measured as the millimeter of water, is 70 to 180. This is normal CSF pressure. Now, these are the normal parameters we have. In case of bacterial meningitis, then what is seen there? So, here, in bacterial meningitis, okay, there are very high number of cells, very increased number of cells. So this is highly variable point. There may be 90,000, there may be 50,000, there just may be 1,000, okay, there may be 2,000, but majority of them are neutrophils. more than 80% or more than 90% of those cells are neutrophil. That shows it is a case of acute bacterial meningitis. If we measure the glucose, okay, glucose is decreased here. Okay, glucose is decreased, means decreased than 2/3 of the blood sugar. In this case, it is written less than 45 because this is a low range. Protein is increased because there is exudation of the fluid. Exudate means rich in protein, so protein will be increased. And pressure is markedly elevated. So these are the hallmarks of bacterial meningitis. So in your exam, okay, one of the case scenario may be asked to you. That case scenario will give some of the clinical feature of meningitis, like a 5-year-old child presents to the hospital with headache, vomiting, and fever for 2 days duration. Okay, during examination, there is neck rigidity, and lumbar puncture was done, and lumbar puncture showed these particular features. What is the diagnosis? And those features would be either of bacterial or viral one, like that. Now, regarding the viral meningitis diagnosis, the number of cells are a bit less than bacterial one. Okay, this again maybe 100 or maybe 50, maybe 1000, maybe 2000, like that. But majority of them are lymphocytes. This is important point. Lymphocytic predominance. Now, glucose is normal. Very, very important feature. Glucose is normal. Protein is increased, but it is not that highly increased like bacterial meningitis. It is increased, but not as that highly increased. And regarding the pressure, it is also slightly elevated. So the most important feature here are two. One, lymphocytic predominance with less number of WBC than bacterial one, and glucose is normal. Now, tubercular or fungal meningitis is a type of chronic meningitis. So in chronic meningitis also, there will be lymphocytic predominance, and the number of cells are quite variable. Regarding the glucose, it is decreased now. This is how we differentiate whether this is a viral meningitis or tubercular meningitis. In both, this picture is same. See that in both there is lymphocytic predominance, but in viral glucose is normal, while in tubercular or fungal glucose is decreased. Protein is increased. It is more increased than viral, and pressure is also moderately elevated. This is how we reach to the diagnosis. Let's move on. Now, what are the other investigations apart from CSF analysis? See there? Another one is CSF culture. Okay, CSF culture. You collect the CSF and send to the micro lab. They will culture it and try to grow the microorganism. At the same time, you can go for gram staining or acid-fast bacilli staining according to the suspected diagnosis. Blood count or CBC, always do that. No need of any discussion. Blood culture is also done because hematogenous route is one of the most important one for meningitis. And blood culture results are positive in almost 90% of the patient with Haemophilus influenza meningitis and 80% of the patient with pneumococcal meningitis. This is a high percentage. 90% of the patient with meningococcal meningitis also have positive blood culture results. Okay. Now, what are the other investigations apart from them? X-ray chest. X-ray chest is done to rule out pneumonia or to rule out tuberculosis. Remember, in case of tubercular meningitis, the focus is from the lung. Any other extrapulmonary TB, the focus is from the lung. So we always try to find out whether there is any active foci now or not, or any old focus like some, a calcified spot, some fibrous lung or something like that. And in case of bacterial pneumonia, okay, or in case of bacterial meningitis, who knows, the source is from the lung. The patient may be having pneumonia first. After pneumonia, the microorganism has gone to the blood, and from there they have entered into the brain. That can happen. So we need to find out the source. Rapid diagnostic tests are done to find out exactly which pathogen is responsible. Now, see here, these are counter-current immunoelectrophoresis, may be used for the rapid identification of Haemophilus influenza type B, Streptococcus pneumoniae, and Neisseria meningitis type A, C, Y, and W135. These are the different serotypes of Neisseria meningitis. So this rapid diagnostic test can be done for this. A negative countercurrent immunoelectrophoresis does not exclude the diagnosis of meningitis by the above organism, but we can go for certain other type of test if those are negative, and this test usually detects antibody. Latex particle agglutination test is another one, okay, which detect both antigen and antibody. So these are commercially available type of kits, we can go for this. Now, after diagnosing bacterial meningitis, now one of the very important part we need to know is how to manage. Now, this is a very serious illness. Sometimes the child is in coma. Sometimes the child is having active seizure. Okay. Sometimes the child is having some paralytic complication. So how to manage all these things together? So we can divide the management into different headings. One is supportive and symptomatic measures or treatment. Another is definitive treatment. If some complication has already occurred, we have to address that as well. And what is chemoprophylaxis? Are there any vaccines available or not? All these things comes under management. Let's talk one after other. Let's talk about supportive measures first. The first 3 to 4 days of treatment of bacterial meningitis are the most critical, so need intensive supportive measures. Vital signs should be recorded every 15 to 30 minutes until the patient is stable. Stable patient means vital signs are within normal limit, or there is no real danger of becoming them abnormal. Then they should be recorded after every hour for 2 to 3 days. Frequent neurological assessment or central nervous system examination is indicated, including pupillary reflex. Pupillary reflex means light reflex. Just show the light on the pupil and check whether they are reactive or not. What is the level of consciousness? It is done by Glasgow Coma scale or ABPU scale. Cranial nerve sign. Examine all the cranial nerves and evaluate for seizures if there are any. With what type of seizure? Is it generalized tonic-clonic seizure or is it partial seizure? Measure the head circumference daily in children less than 18 months of age. Okay, there is high chance of enlargement of the head if hydrocephalus has occurred as a complication. Why children have higher chance of macrocephaly from hydrocephalus, which never seen in adult? Why?
So because frontanelli and sutures are not properly closed in children, that's why surgery increases the chances of the macrocephaly.
Exactly.
Yes,
Exactly. Very good. Okay. I'm sure this is a very easy question and we have explained this before. That is the reason, because sutures are not yet fused. That's why head can still become bigger because of persistent increased pressure inside as a result of hydrocephalus. In adult, head size, it doesn't increase after hydrocephalus. Okay. Only there is increase in pressure. So we need to measure it every day. A strict intake output record is needed. How much fluid the child has taken and what is the amount of urine output. Okay, the record is called input or intake output chart. Because in case of meningitis, syndrome of inappropriate ADH secretion will occur. That is called SIADH. Now, as a result of this, okay, syndrome of inappropriate ADH secretion, there will be more retention of water in the body. that water will dilute the sodium, resulting in dilutional hyponatremia. Okay, so all these things are happening. The child is in coma, probably the child is not drinking properly, so we need to be exact. We have the exact record how much fluid the child is taken and what is the urine out. Otherwise, the child may be hypervolemic. Patient's body weight and serum electrolytes are monitored initially 12 hours, then every day. Serum electrolytes are changed because of SIADs again, and control temperature with cold sponging and antipyretics. There may be high grade temperature, so antipyretics are given, okay, 6 hourly to 4 hourly. Maximum frequency is 4 hourly, and cold sponging if antipyretics are not going to control the fever. Now let's move further. There's so many things we have to discuss here. Another is feeding. What type of feeding, okay, is necessary in this case? Feeding should be continued and given tube feeding, that is NG tube feeding, if necessary. Initially, the patient should receive nothing by mouth, and NG feeding is started when patient is stable. Very important point. Okay, in the beginning, when the vitals are unstable, don't feed the child during that time. There is high chance of choking if you do that. Give IV fluid only during that period, and after 1 to 2 days, when the child becomes stable, when the child is improving, then you start the feeding. Now, what type of fluid we give? It is restricted to 60 to 70% because of inappropriate ADH secretion. That is called SIADH. So you remember one important point. In SIADH, the total amount of fluid which we give is only 2/3 of the maintenance. Now see this is 2/3. 60 to 70% is 2/3 of the maintenance fluid. Calculate the maintenance fluid. You all know how to calculate that, and then calculate 2/3 of the maintenance, then give it. That's the way in case of SIADH. Fluid restriction is not indicated in the presence of hypotension because this may cause decreased cerebral perfusion, pressure causing CNS ischemia. In septic shock, this is not done. Okay, in septic shock, which is quite common in case of meningitis, fluid restriction is not done. A good amount of fluid is given because this is a state of shock. So this 60 to 70% rule doesn't apply there. If the child is in coma, you have to care the comatose patient, like care of the bowel, care of the bladder, care of the skin, care of the position of the child, mouth and airway care. All are important. This is called a care of the comatose patient. Now, what is coma? First, let me ask you, what is coma? Anyone?
Sir, deep
It is state of
loss of the
prolonged
deep
unconsciousness, sir. A state of prolonged unconsciousness.
Okay. Yes. Yeah. Good. Good, Uzair. Yes, Irfan, you are saying something. Go on.
Loss of the consciousness and loss of the deep reflexes are on the stimulation.
Okay. Now, I have not taken a different class about coma, but you should know what is the meaning first. Coma is a deep state of unconsciousness. Deep state of unconsciousness from where a patient cannot be aroused even with painful stimulation. Okay, you are going to pinch the patient. Even if you are going to cut the patient is not going to wake up. This is coma. So this is a deep state of unconsciousness. Now patient doesn't have any feeling there, but just the vitals are maintaining the patient's life. The cardiovascular system is working, the respiratory system is working, but there is no sense at all. The central nervous system is totally depressed. That is coma. So we have to give care to that comatose patient, and after good care, the coma patient may come out of the coma. That is what we expect. So this is very, very important management during this stage. Bowel management means laxatives should be given, to clear the bowel. Bladder, probably catheterization is done. Skin, should be taken care of. Some powders are applied on the skin. Skin should be kept dry as far as possible. Posture, we should change the posture every 2 to 4 hours. Otherwise, the patient has high chance of developing bed sore or pressure sore if you only put the patient in one position. And bed sore management is so difficult. Mouth care should be given. Okay, otherwise there is high chance of ulceration or infection in the mouth. And airway care. Remember, the comatose patient cannot protect the airway. The gag reflex is absent in coma. So if something is there in the oral cavity, it can be easily aspirated. Okay, so the best way to take care of the coma patient is intubation with a cuffed endotracheal tube that doesn't allow anything to go distally in the airway. Seizures are common in a patient with meningitis. So if seizures come, then we have to give IV diazepam or IV lorazepam. These are called benzodiazepine. 0.1 to 0.2 milligram per kg per dose diazepam is given, okay, to immediately stop the seizure. This is the management right at that time. But after the immediate management of seizure, so prolonged acting or long acting drug should be given, okay, to prevent the recurrence of the seizure. And that is either done by phenytoin or phenobarbital in case of pediatric age group. Now, let me give you one example and explain. You are working in the ward, and in front of you, a seizure has come in the meningitis child. You stop that seizure with diazepam. But some seizure will come later on also. So you start a bit of long-acting drug like phenytoin to stop that seizure. Now, with this, supportive management or measures, let's talk about the specific measures, how to treat bacterial meningitis itself. And that is done by antibiotic. When bacterial meningitis is suspected, and after all cultures are obtained, appropriate antibiotics and on the basis of age and epidemiological factor must be initiated. According to age, if it's a neonate, we know what are the organisms. So accordingly, we choose the antibiotic. If it's an older child, we know what are the organisms, so we choose accordingly. From infant in the first month of life are treated with a combination of ampicillin with either gentamicin or cefotaxime. See this, ampicillin is included, one of the antibiotic to cover listeria, and others may be an aminoglycoside or third generation cephalosporin. For low birth weight preterm infant, see this, LBW and preterm, these are high risk factors with late onset meningitis. Late onset meningitis means after 7 days, with anti-staphylococcal agents such as vancomycin and aminoglycosides are used until culture results are available. Because this late onset sepsis is usually caused by staph, and staphylococci, maybe MRSA strain of staph, and that strain has to be treated by vancomycin, isn't it? So everybody knows that until proven otherwise, till culture reports come back. If culture shows no, this is not a case of staphylococci, this is a case of group B streptococci, then we change it. We don't need to give vancomycin after that. How long the therapy is given? What is the duration? See here. The duration of antibiotic therapy for meningitis depends on the causative agents and the clinical response to the therapy. How well the child has responded to the treatment. It also depends on that. Some child are slow responders, so probably a bit longer duration is necessary. Some are quick responders. You can see me now? Yes.
Yes, sir. Yes, sir.
Yes, there's a slight interruption in the middle. Now I'm back online again. Now please pay attention. So what I was talking is the duration of antibiotic therapy for meningitis depends on what is the positive agent and how well the patient has responded. So the minimum duration of therapy for Haemophilus influenza type B and Streptococcus pneumoniae is 10 and 14 days. For Haemophilus influenza, 10 days would be enough. And if it's a Streptococcus pneumoniae, it's 14 days. Whereas the minimum duration of therapy for Neisseria meningitis is 7 days. Okay. Streptococcus agalactiae, if you suspect that, or it is grown in the culture, then we provide it for 14 to 21 days. Gram negatives, okay, 21 days, okay, or 2 weeks beyond the first sterile culture, whichever is longer. So 2 weeks beyond the first sterile culture, you culture the CSF again, and then if that is a negative, another 2 weeks after that. That is the meaning. And in case of Listeria monocytosis, 21 days or longer. Now, one practical problem will be there many of the time. Many of the time, the culture report comes negative. There is no growth in the culture. Then how do you decide whether it is H influenza, whether it is Neisseria meningitis, or whether it is Streptococcus pneumoniae or something else? Isn't it? That's a challenge. So in that situation, what we do, we give for 2 weeks. 2 weeks therapy. Now remember, 2 weeks is somewhere average for all of them. Yes, for Neisseria meningitis, it is a bit longer. And in the middle, we look for the clinical response to the therapy. The clinical response is wonderful. So probably this is a meningitis caused by Neisseria. We can discharge that child a bit early also. So a bit of clinical revision is necessary time and again. Prolonged therapy is required in cases of some complication like subdural empyema, delayed sterilization of CSF, prolonged fever, persistent signs of meningeal irritation, and things like that. This means a delayed type of response, maybe because of some complication like this. So probably 2 to 3 weeks therapy may be necessary in these cases. And sometimes what happens, if the response is not proper, change the antibiotic. Or you upgrade the antibiotic. This is called upgrading the antibiotic. You use some powerful antibiotic than the previous one. Let's move on. Now, what is the role of corticosteroid? Another important point we need to discuss. Why corticosteroids are used in the treatment of meningitis. Dexamethasone in a dose of 0.6 milligram per kg per day in 2 to 4 divided doses is given for 2 to 4 days in case of bacterial meningitis. Now, when to give? The initial dose of steroids should be infused before the initial dose of parenteral antibiotic. First, you confirm the diagnosis, then give corticosteroid, then give antibiotic. This is the way. The exact time, okay, is 15 to 30 minutes after the first antibiotic dose is likely not to be beneficial. Now see this. So it should be given prior to the antibiotic. If we give like this also, then the beneficial chances or the benefit chances will be substantially decreased. But nevertheless, we will give it. Now let's talk a bit practically again. You are not there at the time. You are a consultant, and one of your intern or the resident has diagnosed the disease, and they without knowing these things, they directly started antibiotic. You will not go after them and eat their brain. You say, okay, fine, your management is fine, but it would be nice if you have given steroid before the antibiotic. You talk like that, and still will give it, though the chances are decreased now, but it may help the patient. But remember, the best will be first steroid, then antibiotic. Now, another question, why we give it there? Anybody? Why steroids are given? You can tell me that? What is the role of corticosteroid here in this case? In case of bacterial meningitis treatment?
It reduces the local and systemic inflammation in bacterial meningitis.
Yes.
Okay. Now listen here. There is extensive inflammation going on inside the central nervous system. Extensive inflammation. That inflammation is causing damage there. That's the acute type of inflammation. Later on, okay, if there is a extensive acute inflammation, then that area would be damaged, and then it will be replaced by some glial tissue. So glial tissue is just like a fibrosis inside the brain. So if we stop or restrict or decrease these acute inflammation or severity of acute inflammation, then the subsequent complication of bacterial meningitis would be decreased. I want to compare this mechanism with COVID-19 pneumonia these days. Remember, in COVID-19, infection, which is causing pneumonia, the same type of treatment is done, that is corticosteroid. And the mechanism or the principle why these steroids are used is the same there. We want to decrease the chance of inflammation inside the lung so that the damage done by these inflammatory reactions will be minimal. Now, what are the treatment of other complications if they are developed? For cerebral edema and raised ICP, we can elevate the head end of the bed about 30 degrees. This is called 30-degree elevation of the head. Steroids are already given, and those steroids decrease the meningeal inflammation and brain water content, so they decrease raise intracranial pressure. And at the same time, we can give mannitol as well. Mannitol. What type of drug is mannitol? What is
Osmotic diuretics.
Diuretic, sir.
Osmotic diuretics.
Excellent. Osmotically active diuretic or osmotic diuretic, very good. Never forget, mannitol is very, very commonly used in the treatment of raised intracranial pressure or in the treatment of cerebral edema. Even furosemide can be used, which is another important type of diuretic, loop diuretic. If subdural effusion is there, okay, then we can go for aspiration. We can aspirate the amount of fluid which is collected in the subdural space. First, we need to diagnose it with the help of ultrasound or CT scan. Ultrasound diagnosis is only possible before the fusion of sutures or before the closure of anterior frontal nerve. After that, only CT scan can be done. Inappropriate ADS secretion treatment is already talked about. This is by restriction of the fluid intake. We give fluid only 2/3 of the maintenance in this case. And this SIADH can result in hyponatremia. It can exacerbate coma, seizure. It can lead to weight gain. It can lead to puffiness of the face, decreased urine output, and high urinary specific gravity. All of these are either because of excessive ADH action or because of dilution of the sodium content. Now, if Waterhouse-Friderichsen syndrome is there, then we need to treat specifically for the hypotension, because hypotension is very common now as a result of destruction of the bilateral adrenal gland. Okay, so you need to treat with crystalloid, that is normal saline, or even with plasma, corticosteroid, or even dopamine infusion. After giving a lot of IV fluids, still if the blood pressure doesn't come up, we can use dopamine. Okay, this is the vasopressor agent. Now, at the end, okay, let's talk about what are the complications of meningitis. Let's list them. Increase intracranial pressure, very easy. Cranial nerve palsy, okay, means damage of the cranial nerve. leading to different signs and symptoms. Seizure, okay, very intractable type of seizure, which are difficult to control. Stroke, when there is, thrombus formation in the blood vessel that can result in stroke. Inappropriate ADS secretion, already talked about so many times. And prolonged fever may be due to some intercurrent viral infection or secondary or nosocomial bacterial infection or drug reaction or thrombophlebitis. Now, this is a practical knowledge. Sometimes the patient is getting better, but fever is not disappearing. Fever is still coming. And whenever fever is still there, remember, patient thinks I am not getting better. That is a psychological feeling or effect to the patient. But doctor knows patient is getting better because all the other features of meningitis are disappearing. So that fever may be caused by these mechanisms. Intercurrent viral infection somewhere, nosocomial bacterial infection like UTI, like pneumonia, a drug reaction. The drug which you are giving for the treatment is causing reaction and fever, or because of the thrombophlebitis, because of the IV cannula which you have kept there for the intravenous drug. Who knows? There may be infection of that vein. Blindness and hearing loss. Hearing loss also are some of the important complications of meningitis. Okay. Cerebral or cerebellar herniation can occur in acute stage, especially if we go for lumbar puncture without properly examining the patient. And some long-term neurological abnormality will be there. Long-term, like epilepsy, deafness, this is sensory neural hearing loss, spasticity of the limb, and even visual handicap or squint development in the child. Squint means diplopia. Okay, strabismus or squint is the synonymous term which leads to diplopia. So these are long-term neurological abnormality. So what is the lesson learned? If we can diagnose meningitis in time and treat the patient quickly, we can avoid most of this neurological abnormality. But even with a good treatment or proper treatment, sometimes the neurological abnormality could not be avoided because there is 10% chance of mortality and neurological sequelae after a case of bacterial meningitis. So this is a very serious disease.